Justin, click meeting here and not live streaming on Facebook. Full details, if you're watching it on replay, full details of how to join the sessions are on our website and how to submit a question as well. And just for awareness of people that's in the room, the side part that you can see on your screen, which has the people who are in the room and the chat, that's not recorded. So you can ask your questions in there privately. I'll then put them to Professor Jones, and it's just the two screens of us that's part of the recording that we then upload to YouTube. So that keeps everything nice and private in here. So thank you so much for joining us today. We're going to get started with the questions we've had sent in. We've got quite a general one to start with, and that's around HRT.
Yeah.
So first of all, is it okay to take HRT with PBC? And are there preferred options, for example, patches, tablets, gel? And I'll cut this one into a little mini as well, because it is quite a question that we do get asked quite a lot. So if you want to...
Yes, okay. So there are several aspects to it. So first up, is HRT safe to use in PBC? Yes, it is. Okay. In general terms, one or two caveats, not huge, but the concept that there is any problem with HRT is incorrect. It comes from the fact that sometimes female sex hormones can cause cholestasis, the sort of problem of poor bile flow that is part of PBC. And actually, you see that in cholestasis in pregnancy, you see it sometimes with the pill, you see it less commonly with HRT, but it does happen. That's got nothing to do with PBC. That is a drug reaction or a biological state in pregnancy. It looks like PBC, but it isn't PBC, and it's got nothing to do with it. And that's not more common or less common. That's not more common or less common in people with PBC. So that's where the idea that there might be a problem comes from. Mm-hmm. There are three reasons why you might want to have HRT. So the first is if you've had a hysterectomy with the ovaries taken out. So that's an absolute reason to do that, to go back to a sort of physiological state. So we'll kind of park that, because that's not how most people are thinking about it. So most people are thinking about it for one of two reasons. Historically, it was done to protect bones in women because of the risk of osteoporosis once people are postmenopausal. And I don't think we think that's a good idea anymore, largely because there are other very effective treatments for osteoporosis. So it can be part of the packages of benefits of HRT, but it's, I wouldn't use HRT purely for bone protection. There are simply better ways of doing that in 2025. So the other way is to reduce menopausal symptoms, impact on quality of life. And I think this is where the thinking has changed a lot. And I'm going to give a big mea culpa, which is that I don't think as a doctor, we as a clinic used or thought about this enough. Okay. And we're obviously, as people know, very focused on symptoms and quality of life. And one of the concepts that we use is the pile of problems, if you like. So if somebody has brain fog or fatigue, there's very rarely a single cause for it. There are lots of things that can happen that all add up. Mm-hmm. And the important thing is that sometimes some of the things that are maybe lesser as a contribution are actually easier to treat. And although I don't think menopausal symptoms are worse in PBC or commoner in PBC, I think they add to the other problems of PBC, and they may be much easier to treat. And I think that's where me, myself, some of my colleagues may have been remiss, and we've all been Davina McCall about it, to be frank. And I think all credit to her for highlighting all of that. The other thing, of course, is that I work in my clinic. It's myself and a specialist nurse who people will know, Kath Houghton, who's a lovely, very experienced PBC nurse. And people talk to her about different things to the things they talk about with me. So what we've learned is that to have both of them as there is useful, because the conversations are different. And she tells me that those sorts of conversations are very common indeed. So I think there's it's what people feel comfortable talking about. So where am I in 2025? We talk about it a lot to people. about the potential for it to take away an element of the set of symptoms, not cure PBC fatigue, but it can make a big difference. And certainly we see that in practice. We tend not to prescribe it. It's not really my area of expertise. GPs are much more familiar with it. We do tend to recommend patches rather than tablets, for the simple reason that patches give you a low dose that goes straight into the circulation, whereas tablets give you a high dose, which then goes to the liver, where it gets partly broken down to give you a low dose in the circulation. So if there ever was going to be a problem with the liver, it would happen much more with tablets, because the liver gets the highest dose. So for that reason, which if we don't think there's a liver problem with it, is slightly illogical, I do accept that. But we tend to recommend patches, and people tend to use patches and tend to do very well with it. Is there a cancer risk associated with them? I think you've got to look at individual risks, and I think it comes into family histories and things like that. But not living the best life you can is a risk as well. So I think you can't in life get rid of all risks. You have to decide what's the right risk for you. I think the cancer risk is pretty low, but the GPs are very good advising about it. There is a risk of thrombosis. If you've had a deep vein thrombosis in the past, you need to be cautious about it. I can genuinely say, and all the people I know, who've been on HRT through the clinic, we have never seen a complication of HRT. So if these things happen, they don't happen frequently enough to happen in our patients. And we're, look after about 1,100 people, 90% of whom are women, the majority of whom are sort of peri and postmenopausal. So we would have seen things if they were common. So I think we underused it as part of the all-round package of improving life. We have no hesitations unless there's an obvious family risk factor, and we tend to use patches, probably for illogical reasons, but it's what we do, and it's what we recommend, and our experience is very good with them. So I do think it's something that is an important part of the all-round package. One of the things I do say that's very important is that in general, what we see is doctors who are not familiar with PBC regarding PBC as a reason to not do X, Y, and Z. And we could almost do a whole Q&A session on that, is that the daft things that people have been told that you can't do because you've got PBC. And there's almost nothing that you can't take or do or whatever because you've got PBC. And, there are almost no drugs, literally no drugs that you can't take because you've got PBC. And so this is a classic example of that. And so you could say, well, HRT, what's it? If you were having a hip replacement, we wouldn't get involved in commenting on it. I just know that somebody who wants to go and talk to their GP about HRT, the GP will say, "Oh, I can't make that decision if you've got liver disease." So we tend to preempt that by saying that our view of HRT is as follows.
That's great, thank you. You mentioned Kath as well, your specialist nurse there. We get amazing feedback about specialist nurses at clinic. We'd love to see one at every clinic.
I think so.
Yeah,
I think so. And I think, so what does a Kath bring to it all? Well, the one is continuity. So it's always me or her or both of us. And it's not a revolving cast of junior doctors that I know a lot of people get quite frustrated with. So people have known us, they've known us for years. And that's really helpful. You don't have to go through the story every single time. She just talks about different things. And actually, who she sees, who I see, whether we both see people, is slightly dependent on what their problems are. In general, doctors deal with illness and nurses deal with wellness, if you think about it. And so, but they are really good. She's really good at supporting. So whenever people, change treatments or an itch treatment or go on second-line therapy or something, then she does the early phone calls and check people are right. So she's the easily accessible, always available person. And people know her, and I love it. Actually, when people want to see her rather than me, I think that's great. And I think one of the things that's happening in the health system is multi-professional working. And I think people will have heard about some of the issues with physicians associates and stuff like that. I have to say our experience with them has been very good, but we manage them very well. But different professionals bring different skills. Okay, doctors, I'd be thrown out of the community But doctors are not gods, okay? They don't know everything. They're not gods, okay? And a bit of humility says that I know what I know and I do what I do, and I know that other people know what they know and do what they do, and actually that can be really complementary. And so the different professions bring real skills. That reminds me, I still haven't organised the dietitian that I keep saying. I don't know how many of these calls we've had when I've talked about the dietitian, but it's a perfect example.
I will be in touch with you about
so
that.
I think increasingly the way to deliver sustained long-term care in a condition like PBC is to think of how you can increase the team without it just being more consultants doing it. Because I think that's actually the wrong. You're better to have somebody who cares about it, is interested in it, but then have other team members. She's just great. I mean, you know, she does a lot of work with other nurses around the country, helping perhaps a little less experienced, you know, tips and guidance. And they have a nurse network to answer questions, that things that maybe one of them encountered, and, you know, share it. So it works really well. So I would agree. I think every clinic should have one.
Yeah, no, it's brilliant. Now, I don't think we've.
Well, the other thing is she does our fibro scans. Okay. Here's a trick of the trade. So she does our fibro scan. So we don't book people in at a later date to have a fibro scan somewhere. They pop down the corridor to see Kath. Okay. And here's a trick of the trade. That sometimes if I think somebody's kind of bottling something up, okay, and isn't talking to me, because, you know, I've been talking to people for a long period of time, I will tip Kath off and organise her to do a fibro scan. Okay. And what she's really good at is doing a fibro scan, having a bit of a chit chat while she does the fibro scan. And the number of times that has allowed a conversation to happen. So the fibro scans are good for understanding the disease, but they're also a bit of an icebreaker sometimes to get people to talk. So we do that.
We do hear that as well, actually, is that nurses often have a bit more time to spend with patients as well. So there is more opportunity to have.
If you're going to spend 15 minutes with a fibro scan, why not have a chat while you're doing it? I mean, it's quite boring otherwise. You know, for the patient, you might as well have a little bit of a chat about things. So it works really well.
So we've got a few questions coming in the room here. I'll turn to them just in a minute, but we have got a question that had been sent in to us that I don't think we've had before. Can I donate my body to science, but specifically for PBC research? And if so, how do they go about it?
So you can donate your body to science. There is no program that I'm aware of that particularly would focus on PBC. Okay. I think that's important to say. So all medical schools have a program to do that. So wherever your local medical school is, there will be a contact email for that. And they're very good, and they deal with it in a very sensitive way, and it's done in a very professional way. So the point of contact for it is your local medical school. And then, you know, they will have a conversation about it. But as I say, there's nothing specific in PBC that does that. I mean, I think one of the areas where this has cropped up, and it is around brain research. So, and I've never talked about this at one of these meetings, and maybe that's me, you know. So a lot of Alzheimer's and dementia research has been driven forward by people donating their brains after they've passed on. Okay. And to be able to study those brains, having, you know, in a sense, having had clinical information on people when they're still alive, is very powerful. And that would be a brilliant thing to do in PBC around brain fog, but we've never done it. And part of that is something that I'm not sure I find that, you know, easy to discuss with people, but you introduced it. And I think that is an idea as to a program of being able to study people, and then for them to come into a donation program like that would actually be incredibly powerful. It might be something that we should look at. I mean, Mo, can I ask you, has that cropped up ever before that you're aware of?
No, we're aware of people who have donated their bodies to science, but no one's actually asked us, because we had a chat about it in the office as well, no one's actually asked us, is it possible to direct it specifically to PBC research? And that's why I thought I'd pop it on
I tell you what, let me, would you add it to the list of things for me to do? I will contact the people who do the brain resource. So Newcastle runs the National Brain Resource around dementia, and please do not misinterpret this. Brain fog in PBC is not dementia, okay? And we're not saying that. What we're saying is that the same approach might be useful. But I will talk to the person who does that and seeing, as it was raised by somebody in this forum, what might be the possibility of doing it. It could be incredibly powerful. So I will look into that.
Thank you.
The guy who does that is very nice and very sensitive and very sensible. And I will just find out, because if that is something that people wish to do, it would be, I can tell you from a research perspective, it would be phenomenally powerful. But it's obviously not the easiest thing to talk about with, your own patients, people, and things like that, because it seems like it's one thing if somebody introduces it. It's a little bit strange, if you like, if for us to introduce it in a conversation, if you know what I mean. But I will have a little look at that.
Thank you. Just going to come to the first question we've been asked in the room here. So, patient asking, they've been offered the spring COVID booster, and we'd appreciate your views on that.
Yeah, it's COVID vaccines. So what have I done? What have I done? I had the vaccines at the beginning, and I've not had any of the boosters. So you can read into that what you want. Why have I not done that? Well, because I've had a COVID a couple of times, and it was a bit of a cold, and it wasn't a big deal. So I've never felt the need to do that. My wife is an intensive care consultant who was on the front line in COVID, and she's done the same thing. So amongst clinicians, people have mixed views about it. Where are we with COVID at the moment? It's still around. It's I think reached the endemic phase, which means that it's never going to go away. So it's always going to be there. And these things often over time become milder. And I think there's an element that's done that. I mean, we keep having little waves that come and go. We know from the vaccine, we know from all the way through that the vaccines don't prevent you getting it. They prevent you from dying from it. And so even for people who are vaccinated and have the boosters, you're still going to have these episodes that will be a pretty horrible cold, but you don't tend to get the difficult, you don't tend to get the very difficult sort of lung problems that we saw and the clotting problems. Are the vaccines safe? Yes, as much as any are. There have undoubtedly been side effects with them. I think the AstraZeneca vaccine did cause clotting problems. I think that's now very clear cut, but that vaccine is now gone, is no longer used. We'll call it the Pfizer vaccine, but there are a number that are similar to that, a different way of doing it. They probably do cause inflammation in the heart, particularly in some younger people, very rarely, but it happens. But people died of COVID pretty rarely, but it happens. So it's a risk and benefit thing, which I think is personal. What I do think is PBC, I think what I would say clearly is that if you have cirrhosis or you are on immunotherapy of one form or another, that could be steroids or MMF, or you've had a liver transplant or something like that, or you've got overlap, I think it's very easy. I think you should have the booster in those situations because your immune system isn't quite as strong. So if you don't have cirrhosis weakens your immune system a little bit. So if you don't have cirrhosis or you aren't on drugs that weaken the immune system a little bit, then it's really a personal choice thing. We do know that the risks to people in that group with PBC were very low indeed, but they weren't non-existent. They were no different to the ordinary population. What we know in hindsight, people probably didn't need to shield because they had PBC. It was people with cirrhosis and people, on certain therapies that needed to do that. But, in the early days, it's very difficult to know all of those things. So I think it's a personal choice thing. It's not crazy not to do it. I think it would be strongly encouraged in certain situations that along the lines that I talked about. And if you're not in one of those situations, I think it's personal choice. And I would leave it at that. I mean, I'm very clear the vaccines were transformative. I saw people dying horribly in the first waves of COVID before the vaccines came along, and I never want to see that again. Absolutely. Okay. And vaccines stop that happening. So this idea that the vaccines were a bad thing is nonsense. They were a very good thing, but everyone's vaccinated now, and does repeating that make it an even more good thing? And I think that's where it's less clear cut. Does that make sense?
Yeah. Next question I've got here in the room is there any problem with eating bananas for patients with PBC and cirrhosis? Is that to do with potassium levels?
Yes, so bananas are a very good source of potassium. So Dr. Christie, you're going to join the team now. So you odd interactions of fruit. Okay, so potassium is quite high in bananas. Okay, it's very difficult to eat enough bananas to have a problem with potassium. You do have to watch not so much cirrhosis, but being on spironolactone, which is a diuretic that's often used to treat ascites in people with cirrhosis. So it's spironolactone. You just got to be a little bit careful. But I don't think I've ever seen anybody, have a high potassium even on spironolactone because of eating fruit. Okay. And the other odd one is what fruit should people who've had a transplant or on tacrolimus not eat, Mo?
Grapefruit.
I'm going to go, right? I'm going to leave you with Mr. Rabbit, because between you and Mo, you can do all of this. So Dr. Christie is exactly right. You should watch grapefruit if you are on tacrolimus, because it can push the levels up. And the reason for that, I have no idea, but it's true. And I've certainly seen people tacrolimus toxic because they had a grapefruit.
Really? Just after a small amount?
Yeah. Yeah. I mean, I think the main reason for not eating grapefruit is it's horrible.
It didn't bother me that I had to stay away from them, I have to be honest.
It's one of the things. And the other one is you've got to avoid Brufen. Okay. So you've got to watch Brufen if you're on tacrolimus or cyclosporin, because that can interact with the kidney. So therefore, obscure things. But bananas, no. I think, if your potassium, if your kidneys are a little bit off, which often happens with cirrhosis, you're on spironolactone, maybe you would need to watch it. But otherwise, I think it's absolutely fine.
Okay. I'm going to take one of the other questions we've had sent in. So a question that we've had, my mum had PBC for 30 years and passed away recently. She developed interstitial lung disease, which they think was related to PBC. Have you heard of this?
Yes. So lung disease, there are basically three sorts. Okay. So there is airways disease, that's asthma, where the airway narrows down. Okay. The second is airspace disease, that's a pneumonia, where the air sacs fill with fluid and pus, right? And then the third is what's called interstitial lung disease, where you get swelling of the lining of the lung. So if you think about it, the lung, oxygen goes into it, and it has to get into the bloodstream. The blood vessels are in the lining of the lung sacs. And so they need to be as thin as is possible to allow the oxygen in. And if that thickens for any reason, then oxygen flow across from the airspace into the blood can be affected. And you get some inflammation with that. You get some, sometimes blood flow changes can do that. What's called pulmonary hypertension. You can get some scarring in their pulmonary fibrosis. Okay, so they're all labeled as interstitial lung disease, and it is associated with PBC. Okay, so we do see that, but it's not common. No, that sounds illogical, doesn't it? But PBC is rare. Interstitial lung disease is rare, and so the combination ought to be ultra rare, and it isn't. It's just rare, if you know what I mean. So we do see an association with it. Mm-hmm. We do see pulmonary hypertension a little bit, and that's important to think about. And I think the message here is if you've got PBC and you are getting short of breath, then it's worth getting it looked into. Now, what GPs will tend to do is assume that it's asthma or, chronic obstructive pulmonary disease, because they're common. I think in PBC, you need to do some slightly different tests and think about it. Now, the way you decipher it is, well, with different breathing tests. So there are a number of different tests that they can do to look at where the breathing abnormality is. And actually, you need to do that, because otherwise you won't work it out. And I think if there is some fibrosis developing in the lungs, it becomes important to treat it earlier. There are new and emerging therapies in that area that are important for treating it. It might be commoner in people. You also get it with rheumatoid arthritis as well. You get a bit of scarring in the lungs as well. And it might be that it's where people have got a bit of a combination of things. It's a problem. Do I talk about it to PBC patients when they're diagnosed? No. Okay. It's not common enough for it to be something that we would talk about. Okay. We don't talk about it. However, we would pick up on it and order the tests if people were getting short of breath. And then we have, good colleagues who manage all of this. So it's just a different clinical thing, but it's not a GP diagnosis, is my point. And you, to a hammer, everything looks like a nail. Okay. And so you just need to make sure you don't make assumptions that it's common breathing things in people who have already got an uncommon condition, if you like. So we do see it's not a thing to be particularly worried about. It probably was linked in to PBC. It's probably under-recognised, probably important to diagnose it, because treating it early is going to be the secret in the future. But, we would see, realistically, we would see a couple of people a year with it in a big clinical service. So it's not common.
Just going to go back to the room here. I've been on elafibranor for 1 month. My question is anyone in the UK monitoring everybody on this drug for side effects improvements? And I love this question.
That would seem to be an invitation to talk about national initiatives to collect that information. Yeah, so the short answer is yes, and it's likely to tighten up even further. Okay, so we, through UK PBC, are collecting this information on behalf of NHS England in order to look at the effectiveness of these drugs. So the simple answer is yes, and it's really important. The slightly longer answer is that it's actually even more important than we thought it was going to be. And it's because of the paradox of how do you prove a drug that is effective? Okay, so we know that drugs like elafibranor are very good at improving liver blood tests, pretty quickly. But to the people who approve drugs, that's not enough. They want to know what happens to people longer term. And to know what happens to people longer term, you need to follow them up for a long period of time. But in a clinical trial, that's impossible, because why would you go into a trial and get a placebo when you can just get the drug? And the drug works. It's daft if you think about it. So, I'm glad Robert's not here, because he'll be on the ceiling already by this conversation. And I think I probably spend about 4 hours a day having this conversation with people about it. So we're working really hard with the people who approve drugs to have some common sense. We've got the summit coming up, and we've got a meeting immediately before the summit to talk about all of this. So what do we need to do? What we need to do is, and I don't believe there's a single person out there who would object to this, which is to collect not just the best we can, but to collect really good information on people on a regular basis on these drugs. Now, if you have a liver transplant in the UK, every year we have to fill in a follow-up form which details what your blood tests are like, what's happened to you, what you're able to do. So, and over the years, that gives an enormous amount of information about the value and issues around liver transplantation. Well, we should be doing that with second-line therapy and PBC. So anybody who goes onto a follow-up program, it doesn't mean anything to you as a patient, other than that the NHS will be collecting that information, not because we're interested in it, it's a research project, but because actually we need to know the effectiveness to justify those treatments. Mm-hmm. And then the other thing I think would be, we have to, I was interested by the comment about safety and side effects, because that's really important. And I think one of the difficulties with just asking doctors, what they think, is that they underestimate, under-record potential side effects. So the metaphorical, hair falling out. I can talk about that. I've got a very nice hair piece. Can you tell? Can you see the joint? So we're very poor at collecting that information, and that's really important. So I could envisage a situation where, and people can opt out of it. I mean, that's absolutely fine. But we would ask you for permission to collect your blood test results. We would collect your outcome data in terms of symptoms every year. So you'd be filling in one of the questionnaires that you'll be familiar with. And we would also ask you to notify us if events happened that you felt were related to the treatment. Okay, so finding out the other things that have happened to you. The sorts of things we would collect in a trial, but without the chance element of having a placebo. Okay, and this needs to be done everywhere. It needs to be done collecting the same information, so that France do it and Germany do it, and wherever, because that information really matters. And what we shouldn't be doing is collecting this information in a different way for every drug, because that becomes really inefficient. So there needs to be an initiative to say we must all come together, determine the information we need, make sure it's comfortable for patients. That's really important. And then we have a common way of doing it, so that in 5 years' time, we will have a unique picture of what these drugs do and don't do that will allow us to justify their use in the future. And what this needs is an organization that isn't about an individual academic doing it for themselves, isn't about an individual patient, isn't about an individual company interested in their drug. It would need to be an organization that looks after the interests of PBC patients everywhere, that rises above all of those things. And if only such an organization existed, such as the PBC Foundation, would be fine. So that's what's happening right now. Is this is a big initiative of Robert's. Absolutely applaud it completely, to knock everyone's heads together and say, let's do this in a collegiate way across the world, collect the information. As I said, I don't believe there's a single person out there who wouldn't be happy to do this, because this is the route to be able to have those drugs longer term. So we do it a bit, we can do it better, and we need to do it in a consistent way internationally, and Robert's on the case.
Very much as we are as a team as well. And looking at what happened with OCA, that was the situation we ended up with in OCA, because the information wasn't there, and then it ended up being withdrawn. So
and I think but personally, this is your information and your lives and your futures. You should kind of intellectually own this, if this is deemed not acceptable by the people who approve drugs, I don't know what we're going to do, because we've got drugs that clearly work, and it's unreasonable to expect people to go into placebo trial when they could have the drug. I mean, I wouldn't.
Absolutely.
My family wouldn't. I mean, anyway, so I think, but we have to see the regulators, the people who approve drugs, would have to say that it doesn't do anybody any good to have a drug that really, really doesn't work. It just makes a blood test better, or a drug that is unsafe. I get all of that. I do really genuinely get all of that. However, we do have a lot of evidence that these drugs are safe and very effective. And it's been about, there's been an element of you didn't collect it on a pink form, you collected it on a yellow form, so therefore we're going to ignore it. I have to say there's been a bureaucratic aspect to all of that, which isn't particularly edifying. So we're not going to look at any of that, because it was done in a way that we didn't approve before you did it, even though if you'd asked us to do it that way, you would have approved. Do you get my point? It's a little, what we're after here is the truth. Absolutely. Do these drugs really make a difference? And are they safe? Okay. I think they do make a difference, and I think they're safe. That's based on many thousands of patients over the years, but we do have to prove that. We also have to be sure that they're safe to be used by people who are maybe less familiar and less comfortable with this condition in its kind of weird and wonderful ways. I think it is important. It's, particularly in the more severe end of the disease, it's not straightforward. And so I think, but this is really important. I think this is a flagship initiative for the PBC Foundation. I really do. It's about, and it's the way the world is moving. I mean, amongst, much of the talk about the NHS and doing things in a different way, if you cut behind it all, there is a movement towards much more democracy of healthcare, and it's owned by the people who live with it.
Mm-hmm.
And that's a really good thing, helped by those people who can guide them in doing all of that. And I think PBC has always, people may assume that the way we do things here, is the way it is in every disease. I can tell you it isn't. This is very, very, very different. When I was at a meeting over the last couple of days in rare disease, and we were talking about the things that we do, and people were falling off their chair because they'd never heard of such a thing. And I think so. That's to do, goes back. That's Colette and Robert and Mo and everybody, myself and George, and we've all been a bit of radical thinkers. That good enough is not good enough, if you know what I mean. We've never been like that. And I think there's a coming together of people who think that way, which is very powerful. So when I say disruptive thinking, it's not as in disrupting by shouting. It's by saying, actually, no, that's not good enough. Is that really good enough? Is good enough? And if we didn't have people who thought like that, would have been stuck. Most people in PBC thought Ursa was all you needed, and actually, it was only a very small group of people who said, actually, no.
Mm-hmm.
It might surprise you to hear I was one of them. And my argument was Ursa doesn't improve the symptoms, so how can it be the answer in a treatment if it doesn't touch the symptoms? So anyway, watch this space, and please do make it happen. Okay, because I think it has to, because it's the route to getting the treatments into practice that we want and need.
I have a similar question along the lines for Celadelpar. So we have a patient who's been taking Celadelpar for a month because Urso hasn't improved their ALP in the 5 years they've been on it, and they also had terrible itching. They've just had their bloods done. The ALP phosphorus went down, which is great. However, both their ALT and the AST has went up out of normal range. Do you know if this is common, and if they continue to rise, is it wise to stay on the medication?
Okay, so caveat here, we don't have experience of using Celadelpar in the real world. So there are two worlds in medicine. There is the world of trials, which are quite an artificial thing, where things are very controlled, selected patients, and then there's what you call the real world, which is where you're giving it to ordinary people in the clinic. So all clinicians will tell you trials are great, but this is the irony, of course, is that everyone says we need to have trials to show the true benefits of these drugs, but in truth, you only know what works when you use it in the real world. So actually, I would argue real world evidence is even more important as long as it's collected properly. So I don't have any real world experience of Celadelpar. I've got trial experience. The trials, with the caveat I've just told you, don't suggest an issue with that. However, real world is different. Now, any drug that you take for any reason, people are always concerned that it can cause liver injury. Why? Because most drugs are broken down in the liver, and so therefore you can see liver side effects. So Celadelpar, so like any other drug, they will be watching your liver blood test for two reasons. One is to see if your ALP phos improves, which it has, and the other is to see if there's any evidence of things going awry. Now, what I wouldn't do is panic, and the thing to do with this is to look at the levels of the numbers. So with ALT, so we're all very used to ALP phos, 130 is upper limit normal, 210 is kind of the target for it. So we're used to those sorts of numbers. ALT operates in a different way. So the upper limit normal is 40. Minor elevations aren't that important, but if you had a hepatitis A, so if you had a hepatitis A enough to make you feel a bit under the weather and not want to go to work, you might have an ALT of 20,000, right? So the numbers scale, you never see an ALP phos of 20,000, right? So the numbers can be on a completely different scale. So you do need to be aware of that. Conventionally, we don't particularly worry about an ALT unless it's above about 60 to 80. Different people would have a different cutoff. And where you would say it was worrying would be depending on how fast it was rising. Okay, so those are the ballpark figures you need to think about. But if it's 40 and change, don't worry about it unless it becomes a sustained trend. The right thing to do always with any drug ever where you think that the drug is making you worse is to stop it, okay, and to contact your clinician and to take stock of it, okay. So drugs cause really bad things to people where people continue them after bad things have happened. Okay, and I've in my career, unfortunately, come across not in PBC, I would add, by the way, horrendous cases of this. And if I was to say that these were cases where I was writing reports on behalf of the coroner and the police about whether this constituted negligent manslaughter, you will understand where we are in this, which include people continuing on drugs where it causes liver injury, even though they said, shouldn't I stop the drug? I was warned if my liver got worse, I had to stop the drug, being belittled, and every member of the team saying, shouldn't we stop this drug? And a consultant saying, no, I'm the consultant, you must continue the drug, and ending up with somebody's death, right? So you must, so actually that led to textbooks. That case led to us changing what was said in textbooks for medical students to say explicitly, if you suspect liver injury in anybody from a drug, you stop it, not tiny rises, but a sustained and progressive rise. So if in doubt, particularly with a drug like Celadelpar, where you can stop it, if in doubt, you stop it, take stock, and then you can restart it. There's no problem with that. It doesn't. So if in doubt, you stop it, and then you restart it. Okay. We don't have enough data in the real world to know if there's an issue with it. The trials didn't suggest it was an issue. But if it is above the sort of 60 level or rising rapidly or anything else like that, the sensible thing is to stop it, get in touch with the doctor and revisit it, is my personal view.
Great, thank you. I'm just going to come back into the room here. We've got a patient who's expecting shoulder.
Oh, by the way, I said before, plot spoiler, doctors are not gods, okay? You look at some of the cases like that one, and boy, do you realise doctors are not gods.
So we've got a patient who's expecting shoulder surgery, interested in knowing which types of painkillers you would recommend safe for use considering PBC. Diagnosed 2 years ago, and the ultrasound and fibre scans showed no damage. And they're joining us from Slovenia. Very welcome.
Yeah, so first thing is the most important thing after shoulder surgery is actually physiotherapy, okay? Because shoulders, very easy to lose range of movement and not get it back. So pain control to be able to do physiotherapy is absolutely critical, okay? So it's a really important point, okay? And if you lose function in your shoulder much more than you would do with your hip or your knee, right? So I don't have any prescription about painkillers at all in PBC. There is an urban myth out there about not being able to take Brufen in PBC. I do not know where it comes from. There is no evidence about that at all. We routinely recommend people, the kind of bedrock for that type of surgery would be regular ibuprofen. Now, the only thing to watch out for, depends what your surgery what you're having, is that if you're having joint replacement, some surgeons are anti-Brufen, okay? Now, as many of you know, I had my knee replaced about a year ago, and it's very interesting is that the orthopedic surgeons split into two types: those who are vehemently opposed to Brufen and those who are very philosophical about it. So there is some evidence about bone healing being less with Brufen. I'm a scientist, I evaluate evidence, and I took Brufen after my knee replacement and I'm fine. So just be aware of that you might hear that. I think the evidence is a bit weak. As I said, if the price of having full mobility in your shoulder through being able to do physio is Brufen, then you take Brufen, because loss of mobility is the most important thing. One of the odd things that people are often surprised by is you actually find taking paracetamol. Paracetamol is the best analgesic in people with liver disease. Paracetamol is only toxic in overdose. And particularly if you're not cirrhotic, you're fine to take paracetamol. Watch out for other medicines that include paracetamol. That one of the things that we see very sadly occasionally is people who take what's called an inadvertent overdose paracetamol. So maybe they're taking paracetamol, they're feeling rotten, they're maybe not thinking things through, and so they take some night nurse as well. They take a full dose of night nurse, and that's actually enough paracetamol to give you liver failure. So it isn't people taking too much paracetamol, it's them taking paracetamol plus something else. What about cocodamol? Just watch out for the opiate in it. So codeine is an opiate, and opiates can make itch worse. Okay, so certainly people with PBC itch, opiates can make it worse. So if you've got a problem with itch, I might just be a little bit cautious about that, and I'd be very cautious about much stronger opiates, so tramadol and OxyContin and morphine and things like that. Maybe a couple of days to get the worst, if it's joint replacement, a couple of days to get the worst of the pain over with. But I had oral morphine after my knee replacement, and it worked in the sense that it stopped me bothering about my knee, because I felt so miserable with the morphine. So actually these analgesics are not the answer to things. So a baseline regular Brufen, maybe even just once a day to keep things under control, then top it up with paracetamol plus and maybe a little bit of codeine, but watch for the itch, and most of all keep your mobility up. Oh, and ice, right? Ice. Anyone think I had joint replacement recently? Ice is your friend. So what you need to do is get plenty of ice packs, ice cubes, and when you do your physio, put an ice pack on it after you've done that to bring the swelling down, because it's the swelling that becomes a problem and then leads to restriction of movement. So don't automatically go for treat tablets, go for other things like ice.
Okay.
If you look at sportsmen who have an injury, the ice pack is straight on. Okay, they come off the field and the ice pack is on, and that's because it's the swelling that causes the problems.
Great, thank you. Another question in the room here: do you believe it's possible to reverse mild cirrhosis? Yes. Okay. So cirrhosis, let's unpack that. Cirrhosis is not cirrhosis is not cirrhosis. People might think that isn't cirrhosis is the mild and advanced, and actually there is different types of it. There are different grades of cirrhosis. So really long-term embedded cirrhosis, scar formation that's been there for a long period of time, probably not. But fibrosis and early cirrhosis, where that's become more extensive, the scar isn't fixed. It does remodel, grow and break down all the time. And so if you can tip that balance into more breakdown than growth, you can reverse it. So there is evidence from autoimmune hepatitis with full control of the disease, viral hepatitis, that you can get reversal of more advanced fibrosis and early cirrhosis. Okay, it's not been studied really at all in PBC for two reasons. One is we don't do biopsies, and so these studies really need biopsy to look at them. And then the other is that to get any reversal of cirrhosis, you would need complete control of the disease. And the thing is that we now have the capacity to give you complete control of the disease. So I think in the days of Urso, improving your blood tests and a bit of improvement is okay. That isn't full disease control, and you wouldn't see cirrhosis reversal. I think where we're normalizing blood tests, I think we're into a different world. And I think this is one of the arguments. I think it's a really good question. I think that's why we are in the world of wanting to normalize blood tests, because I think that gives you the position. So if I had early cirrhosis with any type of liver disease, I would want to have complete control of the disease to allow nature to take its course and to remodel it. It's not going to happen quickly, but it will happen. And I think it's very important. The second line therapies, all of them basically, are probably antifibrotic as well. So they all naturally encourage that. So I think if you look at elafibranor, if you take it with early cirrhosis, you both get the controlling the disease bit, but you also get a boost to the regression of the fibrosis. So yes, and I think it's a reason to be even more cautious, even more keen to normalize blood tests in people. Be careful though, once cirrhosis becomes advanced, those treatments become a problem, not a solution. So it's not a zero-sum game. So once you get cirrhosis complications, they can be problematic. So yes, early, no, late, and in fact, you're not going to get to the conditions to do that. But I think it's very important. Great. Another one we have in the room here, latest FibroScan was 19 on Urso and bezafibrate. I have my next appointment late April. Any tips on what to ask patients in Northern Ireland?
So, can I ask you to put in the chat how old you are? That's a terrible question. Do we know how old this person is?
25-ish, if anybody's interested.
Sorry?
I'm 25-ish, if anyone's interested.
You're 25-ish.
Yeah, always, forever.
Yeah, 67.
67.
Okay, so the FibroScan of 19 is too high. Okay, I would like that better than that. It's not terrible, but it's too high, and it is potentially into the cirrhotic range. 17.9 is the conventional cutoff that most people use. Now, it's not as simple as that, and you'd want to look at the other things going on around it. So I'd want to look at the bilirubin level, because if the bilirubin is elevated, that causes me concern. I'd want to know if the platelet count was reduced, because that would cause me concern. These are all features of it being important change in the liver. Okay, so I want to, at a FibroScan of 19, I'd want to get some more information about exactly where does this lie, what is the risk profile here. Okay, at a FibroScan of 19, probably bezafibrate is not the right treatment. Okay, so you would want to be looking, so you're obviously on second line therapy, but I think in 2025 there are better options than bezafibrate, more studied, more antifibrotic, more effective. Okay, so I would be looking for one of the other second line therapies, and if you're doing otherwise well on bezafibrate, then elafibranor is probably the obvious choice, because that's the one that's most widely used. It's like a more effective version of bezafibrate and better studied in PBC. Okay, now there was one bit, so in simple things is that this needs attention to detail. I want a bilirubin that's normal. I want alk phos that's normal in this situation. I want a FibroScan value that's coming down. And after all of those things, I'm a bit happier. And it's whatever you need to do to achieve that. Okay. Now, there's one bit of your story that's slightly problematic, and that's that you live in Northern Ireland, because as Mo will probably have experienced on the chat line, it's a bit of a mess with regard to second line therapy in Ireland and in Northern Ireland. And we don't do politics here, but to do with Brexit and regulatory authorities. And I've just come off a call with a Northern Ireland colleague, who's pulling her hair out about all these sorts of things. So all things being equal, I would go for personally, I'd go for something a little bit meatier than bezafibrate with Urso, and elafibranor would probably be the choice because it's the nearest like-for-like substitution. But the issue will be about availability of it in Northern Ireland. And I think, Mo, what have you heard about the situation with second-line therapy in Northern Ireland?
I haven't heard that it's been approved yet in terms of for access to elafibranor, but I can check that. If the patient wants to drop me a little email at mo@bbcfoundation.org.uk, I'll follow that up separate as well.
Yeah.
And
I think if people are
100% sure,
I think if people are being disadvantaged by bureaucracy, that's not good. And so I think we'd be keen to pick that up and make a case for it. So in England, you'd go on to, we would talk through the options for you, look at the whole picture and decide whether on the one hand, it's a number and you're doing very well otherwise, or the other is you want better control. But I would look at FibroScan 19. I think I'd like that under 15, okay, and then I'd be happier. Below 10 would make me really happy, but that might be tough. So you need the best control. And I think if you've crossed the line second line therapy, you now need to be on the most effective, best supported second line therapy, which I think in that situation is probably elafibranor. Mm-hmm. Obeticholic acid. We can talk about the issues with OCA. They are very complicated. It is probably the most antifibrotic of these drugs because of how it works. So, but again, that its regulatory position in Northern Ireland is very complicated, because is Northern Ireland in the UK or in Europe when it comes to regulatory agencies? Even the regulatory agencies can't tell us that.
Just going to say as well, if you think it would benefit to have a little chat with us on the helpline before you go for your appointment in April, please do that. Reach out and we can have a chat. So help you put together what you want, what we've taken from here today, and what you'd want to ask.
I think so, and have a chat with them, Mo, about the other blood tests that she knows the values that we're looking for, because FibroScan is part of the picture. It's an important part of the picture, but it is not the whole picture.
Mm-hmm.
And actually, is this 19 and otherwise fine, in which case less of a concern? Is it part of a signal that you would need to be a little bit worried? The art with PBC is attention to detail. Every person is an individual, every person is different, and to pay attention to all the details. And if we were all to do that, so some numbers. Okay, right. So patient ALP-FOS 104, gamma GT 152, bilirubin 6. So those are really good numbers. Okay, so those are really good. Platelet count is the other one. I want to see that above 200 really, and certainly above 150. So that suggests quite inactive disease. So there's activity and there's severity. Severity is how much scarring is there from the past. Activity is how much inflammation is that will lead to scarring in the future. So that looks like quite inactive, but moderately advanced disease. That's not an illogical combination.
Mm-hmm.
In which case, actually, the question we had about early cirrhosis reversing is exactly the right question. So how would you get that FibroScan value down? Well, you'd want to keep that level of control, which is really good, and you would want to have possibly more anti-fibrotic action, and that's where probably the newer drugs are better. And they could say, well, your clinician might say, well, you can't do better than ALP-FOS 104. I get that, but that's 104 with a FibroScan of 19. So that's presumably either stayed the same or has happened on bezafibrate, and so that indicates that's where you want to tighten it up. So to remember, and Mo will be very happy to talk about this concept, that it isn't just it is the biochemistry up here. That's how active it is. The FibroScan is how severe it is, and it's about you want to be in the bottom left-hand corner, inactive, no severity, but all variations in between. It's like a graph where you can plot a point anywhere.
Mm-hmm. Great. Can I just say as well, it's been really good. I know this is the first week we're just in the room here, but there has been real good interaction that we've been able to do, because we are just in the room here.
Oh, honestly.
Further questions and good answers, and it's been great.
As Mo always says at the beginning, we don't want, it's not really the right thing to do to talk about, an individual's healthcare. However, cases, stories like the last one are really informative, because we've had a thread here. We've never talked about this before. Early cirrhosis, does it reverse? We've actually had a couple of aspects of that. And actually, hopefully I've given you some sense of the things. What are we looking at? So when we look at the tests, we aren't just going, oh, look at those. We are actually answering a whole series of very specific questions. And the answer to that is very useful, because it leads you to different places. So to have that little bit of information makes, I think, it more informative for everybody, because those, the numbers are very informative like that. Oh, we got time for one more?
We do have time for one more. I don't think there's an active one in here at the moment. I was going to go to one that had been sent in, because it's about one of the other new drugs. PBC itch has a huge impact on many patients in terms of severity. I believe one of the new drugs, linerixibat, is currently in stage 3 trials.
Yeah.
How does this drug work differently from the current drugs with the likes of cholestyramine and rivampicin that were already used in the UK? We already have the new second-line treatments for PBC, so it's interesting to know what is different about linerixibat as a new itch treatment, which is debilitating as a disease itself and many compared to drugs on the market.
Okay, so I have 5 minutes more if you have.
Perfect. Yes.
Because that's a really good question, very topical. Okay, so what is linerixibat? So linerixibat has finished phase 3 trials. The data are about to be published. It is positive, the trial. which shows that it is effective. So in trials, you either meet the endpoint, it works, or you don't meet the endpoint, it doesn't work. So that's how it works. So it works in phase 3. So they will now move forward to licensing it, okay, to make it available. That's really good news, because in itch, you want as many options as you can, because individuals will respond in different ways. So it is the first modern era trial of an itch therapy specifically for itch, which, if you think about it, is what you want. And so it's a landmark in PBC, okay? And then, and no, I'm not sure, you may know this, it only happened because of the PBC Foundation, okay? Then do you know this?
I don't think so.
So we'd been talking to JSK, who make the drug and are running the trials, about this. They'd had this molecule, it was potentially interesting, and but they came back to us and they said, oh, itch can never be bad enough. Why would we want to develop an itch treatment? You know, what's wrong with antihistamines? Itch is never going to be, you know, enough of a problem. Okay. Now, Colette Thane of this parish got quite annoyed at that, as you might
imagine,
as I did. And so we said, would you like us to come and show and explain this? Okay. And so we got on a train trip to Stevenage, to the headquarters of GSK. Okay. And we had, I think, 4 of us, myself, Colette, a couple of other members, and then somebody done a film about what it meant. And we went, an audience of people, it was a science to talk about it. It was an open forum where people could talk about their experiences. And, you know, it's not, I can talk the hind legs of a donkey. I talk for a living. It's not something people necessarily are comfortable with. And the people were brilliant at it, moving, you know, and that was it. And we didn't know that the board of GSK were dialed in to watch this online. So it was an audience in front of us. And at the end of it, they said, we get it completely. We'll support the program. Okay. We needed to hear that, and wow, you know. And so really important example of, they need to hear it, but not histrionic, you know, the end of the world, the end of the world. Cold, dispassionate. This is what it means to me and my family, right? Incredibly influential. And that program wouldn't have happened without that. So I just think it's a lovely example of that specific drug, now proven to be effective, wouldn't have happened without the advocacy of the PBC. Did you know that?
I didn't know that detail from the beginning. No, I have worked with GSK since starting in terms of moving the drug forward, and I would have to say the team that.
But you can imagine what Colette felt like when they said, we don't think itch is bad enough. So
very patient-centric,
actually, some of them were still
very understanding. Yeah.
Anyway, so what it does, so it is a completely different type of drug, and it is best thought of as mega cholestyramine. Okay, so cholestyramine, basically you take it, it's gloop. Everyone who takes it knows it's a gloop, and that gloop binds bile acids in your bowel, and those bile acids are normally taken back up into the body, go round, and it's those bile acids that cause the itch. Okay, so particular types of bile acid in PBC, they go round and they cause the itch. And what the cholestyramine does is bind it all together. It passes out into your stool, and so it reduces the bile acid levels. That's how cholestyramine works. Now, you will all be, who've taken it, will be very familiar. It's pretty foul stuff, and it's also not very effective in practice because it's pretty foul stuff and people struggle with it. And also, to try and bind every bile acid molecule is really difficult because it's throughout the bowel. And what's really smart about linerixibat is it takes a different approach to this. Is you don't have to bind up every bile acid in the bowel. You just simply have to block the route by which they're taken back up. So what it does is it doesn't try and bind the bile acids, it stops them going back up into the body. So it's much easier to get a complete block, basically. You don't have to hoover up everything, you just have to prevent any of it being reabsorbed. So therefore it doesn't matter. So that's how it works. There's a version that's used in children. It's transformative for children with some of the genetic cholestatic diseases, where you can imagine babies with horrendous itch, you know, they have the same itch that people with bad PBC have, but they're babies and they don't understand. So it really is extraordinarily effective. So It's been a long journey with PBC. It's now positive, and it will all move the way through. So what does it do compared to, say, rifampicin? So it's like a much better version of Questran, right? I mean, in simple terms, and it doesn't have the gloopy side effect. So it's a completely different type of drug. So it has that advantage. It's completely different to rifampicin. So rifampicin promotes the liver breaking the bile acids down. So it's potentially additive to rifampicin. So one of the things we'll need to explore in the future is combinations of these treatments. Questran plus linerixibat won't make sense because they're two things doing the same thing. But linerixibat plus rifampicin would be additive. Okay. So would I, running a specialist itch management service, like to have access to linerixibat? You bet I would. And we'll be starting to use it pretty quickly because we'll start to get it on a named patient basis. And then we'll go back to what I said before, is it's only in the real world you discover how useful these things are. But we do see, and people on this call are familiar, that some people have a liver transplant for how bad their itch is. We need better options, okay? So is this for everybody? Is this for people with bad disease? Is this, we will find that out when we get to use it in practice, but it works in severe itch. And that's really important. Now, do you need it when we have elafibranor and Celadelpar? Now, you will hear from the companies who make elafibranor and Celadelpar that they are the answer to everything. They are like unicorn tears, okay? And these drugs are the answer to itch. Now, let's unpack that a little bit. The trials showed in patients who happened to have itch when the drug was used for second-line therapy, which is actually a small minority of people. These were not people being treated for itch. There were people being treated for biochemistry who happened to have itch. In those people, there was a modest improvement in their itch. Okay, now that's not the same as being a treatment for itch. That is a good option for people who need second-line therapy who have itch. And I personally think that some of the benefits of these, based on the data that we've got, have been a little oversold. So bezafibrate is the same. It is a useful drug. We use it in our itch clinic. In people, it's one of the options we use. It is not a game-changing drug for itch, in my experience, but we run a dedicated itch service, so we kind of see people with a real problem. Elafibranor does seem to be pretty good, actually. I have to say, we've got some experience of that. Would it be useful in people who only need an itch treatment? I don't know, because we're not allowed to use it. We're only allowed to use it in people who need second-line therapy, and most people we see with itch don't need second-line therapy. So it's only, conceivably a treatment for people who also need second-line therapy. So you need to be slightly aware of that. Personally, I think we need to do trials of it as an itch therapy. So does this work in people with severe itch who otherwise don't need second-line therapy, yes or no? And that needs a specific trial to look at it. Personally, I think that we need itch treatments and we need disease controlling treatments, and I'm not sure there's that much overlap between them. And I think if you need both, it's useful to treat an agent with an agent that might cover both the bases. You certainly wouldn't want to give opioid, which might make the itch worse. So if I had somebody who had bad itch and had a need for second-line therapy, of course it would influence the treatment that I gave, but I would also be warning people this may help, it may not. Don't worry if it doesn't, we'll add something else in. So I think these are part of the answer for itch in some people, but they are not absolutely the answer to itch in everybody, not least because we can't actually use them in people whose main problem is itch. So linerixibat is a step forward, and I think that's very important, and it will make it'll make life easier to have it. The other thing is that in the real life, in the real world, people can't tolerate treatments, and you get this all the time with statins. Oh, you just need to, nobody has side effects of statins. Yes, you do. You need to have options for treatments, and the more options we've got. So it is much better for all of us that we've got URSO, and then we've got OCA or bezafibrate or elafibranor or Celadelpar, because they will work in different ways. So they'll work to different degrees in different people, but they'll also be tolerable to different people in different ways, because tolerability is something it's very difficult to predict. And that's the important thing. It makes it that much more likely that you will have something that will work for you. So that's why it's important. There was a comment about somebody feeling they're in medical limbo, and the advice for all of this. Honestly, these sessions, please do dial into them. I mean, obviously mine are the best, but because they have the added rabbit, really. But I'm joking. Different people have different experts, have a different take on it, and they have a different way of doing it. And it's really valuable to hear those different thoughts. I think that is so useful. We have these conversations ourselves, and 90% of the things we do it the same way, but we'll have slight differences. And I think that's really useful. But we do this willingly. We enjoy doing it. You've probably detected that. We think it's an incredibly valuable thing. And the foundation is a phenomenally valuable source of information of the highest quality. And so nobody in the world should feel they can't get access to information about PBC, because if nowhere else, then get it from the foundation. So, and you can trust what we say, because we work very carefully on making sure that what we say is correct. And that's not always true of things on the internet. Another plot spoiler.
Yes.
You can't believe everything you can in the PBC Foundation.
Sometimes questions come in for these sessions as submitting a question, and we actually see there's more to it, and we turn it into a helpline call and speak to the patient separately. So
yeah, and the other one is
some of that as well, you know.
Yeah, and the other one is we pick up topics that we then put into the bare, we expand a little bit into the bare facts. And I think Mo's doing some work on pulling out elements of these and putting little, bite-sized segments and things like that.
Yeah.
I don't think in all the years I've done this, and it is years now, I've ever been asked a stupid question, okay? Ever, right? And I've been asked, I'm astounded by the fact that we still keep coming up with new and original questions after all these years of doing it. And I think what we've all become very good at is using them to illustrate a point and making it more generally applicable. I think that's one of the things that's quite useful, and hopefully people find them enjoyable. As I say, we enjoy doing them, and I think if anything good came out of COVID, it's probably this. Because we'd never done this before COVID.
No, and I think the fact that we can continue to do them, and I love when I get the questions in and I review the questions before I send them on to you, is that you can see our patients are really well informed as well. We get lots of questions.
Well, they're good questions.
Yes, really, which is brilliant. And it does allow us to talk about the new treatments and things that are coming along as well.
Oh yeah, I mean, people are so up to speed with it all. Actually, but then we do contextualize it for people who kind of need a bit more information. I do think the new platform is a way to do it, because I think it also allows it to be more interactive.
Yes.
Which I think we've had a couple of examples of that, because I think that's very good. But as long as you don't get that issue, but you've not had any of that issue with the rabbit, so as long as that doesn't happen, you'll be okay.
On that note, thank you so much for joining us today, Professor. That's been another brilliant session. And I look forward to seeing you next time. Thanks to everyone who joined us today on the new way of doing it today. We've had a great attendance today and a really interactive session, which has been brilliant. So thank you so much for that. I'll get this session up onto YouTube as well.
Okay. See you, everybody.
Take care. See you soon.